Well, let's go ahead and get started this afternoon. I want to welcome all of you to our afternoon program today. Thank you all so much for coming. This is going to be a really special program. I am honored today to introduce my friend and a professor, I'm happy to say, from the School of Dentistry, Dr. Charles Cobb. Dr. Cobb and I have had the pleasure of working together at the School of Dentistry. Somebody asked him how long he'd been there, but I think we were both there 40 years together and shared a lot of lunches, so I kind of know Charlie pretty well. But I thank him in advance for coming today. Dr. Cobb graduated from our School of Dentistry in 1964 with his DDS. He then pursued a certificate in periodontics, which in our words is the gums and supporting structures, and an MS in microbiology, both from our school, in '66. He then did active duty with the U.S. Navy from '66 to '68. He then, after getting out of the Navy, went to Georgetown University in Washington, D.C., where he achieved his PhD in anatomy with emphasis in microscopic anatomy and cell biology, and this was in 1971. He held teaching and research positions at Louisiana State University, University of Alabama in Birmingham, and before returning to Kansas City and UMKC. He was a private practice periodontist for 15 years in Kansas City, Missouri. Dr. Cobb is one of the most published people I know, and in fact, I have to give a little kudos to him. When I was pursuing tenure, this guy helped me a lot. I probably wouldn't be standing here today had he not helped me with some things when I was pursuing tenure, and I haven't forgotten it, Charlie. He has published 270 plus peer-reviewed articles and 5 book chapters. He presented 250 plus programs at regional, national, and international meetings. He's retired from the U.S. Army Reserves with the rank of colonel. He was inducted into the Order of Military Medical Merit. He was UMKC Alumnus of the Year in 1995. He received the President's Citation for Outstanding Alumni Service in 2001 with the University of Missouri System Alumni Alliance Association. And this is the most fun fact. Dr. Cobb was a 3-year letterman in baseball at the University of Kansas City, and he played for the Louisville Redbirds, at that time a farm team for the St. Louis Cardinals. Can you believe it? We have a celebrity among us. I'm honored to present today Dr. Charles Cobb.
I didn't expect you to read all that.
You're important.
Thank you, Connie. I didn't expect that introduction. Playing baseball is why I have 2 artificial hips and a bad back. Well, we're going to talk, this is not going to be a pleasant presentation for some. It could be a little on the gross side, as the students like to say. Not working.
Well,
Well, at any rate,
Well, I have a question already.
You have
What
to keep it.
position did you play in baseball?
I was catching.
No wonder your knees are bad.
Oh, my knees are fine. It's my hips that are bad. I caught my last game at the age of 56.
Cool.
And went downhill from there. Okay, this title could be interpreted in a couple of different ways. One is there a relationship between the two? And actually we're going to talk about the bacteria of periodontal disease. In this case, periodontal disease will be periodontitis. That's the name of the most common of the periodontal diseases. And is the inflammation of that disease associated with any type of systemic disease? Is that Jim Lowe?
Yep.
It is.
Good grief. More, more commonly, and I was talking to Dr. O'Banion over here earlier, that it seems like medicine somewhere back in the 1920s divorced the mouth from the rest of the body. And here we are almost 100 years later, we're trying to put the mouth back into the body. So that's what we're going to do here today. I became interested in this subject about 2010, well after I had retired from the school, but I was still lecturing a little bit, I was still teaching part-time, and I was writing quite a bit. And I began to pull the literature from about 15 or 20 different journals, looking at the table of contents, finding articles that interested me, and then I would pull them up on the web and read them. I still do that because the library allows me to do that, otherwise I wouldn't be able to. It became obvious to me, though, that there were a cluster of diseases that are all kind of related and that they all involve some degree of inflammation and atherosclerosis. So I began to focus on those, and ultimately I began to focus on Alzheimer's for obvious reasons. I'm of that age group. And it became, again, obvious to me that most of that literature is very confusing. A lot of the people who are doing research, for some reason, don't understand differences in experimental design to take into account things like confounding variables, confounders, comorbidity, conflation, association, causality. They don't make those distinctions many times, so the literature is sometimes not very reliable unless you yourself understand those things. Almost all of them can establish a biologic plausibility. These are healthy mouths, healthy teeth. I'm of the old school that you have to understand what normal looks like before you can understand abnormal. And you'll notice that over the years, there's almost 50 years difference between 25 and 70-year-old mouth there. Not a lot changes, except in the 70-year-old you begin to see a little bit of gingival recession. You're getting longer in the tooth, so to speak. It's not because your teeth are getting longer, it's that your gums are receding. Some of the literature in theoretical microbiology says that there are more bacteria in our bodies and on our bodies than there are cells that make up our bodies. That we are literally a walking pile of bacteria. And that when we look at each other, we're seeing what we think is skin, facial features, but it's covered with bacteria. In fact, if you look at the, this varies because it's not, obviously not established what the numbers are, it's approximate. 43% human cells versus 57% bacteria. If you look at the genomes, the human genome, that has in it roughly 20 to somewhere between 20, 23, 25,000 genes. If you look at the bacterial genome, you're looking at roughly 46 million genes. And if you figure out the ratios of that, that can be anywhere from 1 to 1,800 up to 1 to 2,300. So the question arises, who's in charge, us or them? I would suggest to you it's them. Because that bacterial genome can play a role in disease like obesity, asthma, allergies, inflammation or inflammatory bowel disease, type 2 diabetes. It can predispose us to develop those problems. Microbiologists have divided that microbiome into roughly 7 anatomic specific microbiomes. What that means is skin will have a set of bacteria that are common to it, and they differ a little bit, and in some respects maybe a lot, to the microbiome you might find in the gut. And certainly the mouth is even different yet. So we're dealing in this presentation with the mouth. Consider, if you will, that if you have 1 cubic millimeter of dental plaque, that is roughly a milligram, and in that milligram you have roughly 100 million bacteria. If you don't remove that 100 million bacteria, it collects at the margin of the gingiva or the gum tissue. If you don't remove it and you allow it to stay there for a period of about 14 days, which sounds like a long time, but you'd be surprised how many people miss a spot for 14 days. You'll develop inflammation in that area. Very localized at first. Now, if you're one of my students, I tell you to stand in the back of the room.
I'll sit in the front and listen.
Look at this another way. If you've got a gram of plaque, you've got 6 trillion bacteria in that gram of plaque. There are roughly 14 different taxonomic groups of bacteria in the human mouth. 700, about a little over that, distinct species. About 200 of those are found in dental plaque. The rest of them are floating around. We call them planktonic. They don't attach and develop into plaque. The plaque can give up bacteria to become planktonic. Some of those can settle out and colonize to become part of the plaque. So it's a balancing act. Roughly 30 species of those plaque bacteria are involved directly in the development of periodontal disease. And you notice it's inflammatory periodontal disease. That's a key word, inflammatory. The top 10 pathogens, one we're going to focus on is Porphyromonas gingivalis, number 1 on that list. You'll see that name come up time and time again. The rest of those are definitely players, but Porphyromonas gingivalis and Fusobacterium nucleatum seem to be the really invasive bacteria. We find them in atherosclerotic plaque of the arteries. We find them in the brain, in Alzheimer's, on autopsy. They're very invasive organisms. The last one there, we will have all of us recite that very quickly. Aggregated bacteria actinomycetum comitans. Okay? Only a Spaniard can do that. It turns out that amongst married couples, and actually families and children too, that if you start out with very disparate bacterial floras, that over time you graduate to the mean or the median. Everybody's in the family, their bacterial flora ends up looking alike. So if mom and dad got periodontal disease, the kids probably will develop it along about puberty. I threw these in just so you can see what bacteria look like. It's easy to talk about. I mean, you see pictures in Time magazine or some magazine, but these are actual electron scanning micrographs. It's an 8,000 magnification. And you can see the little round tennis ball types. Those are cocci. There are various lengths of sausage-shaped bacteria. We call those rods. The very long rods, those are probably going to be Fusobacterium. These others, they could be most anything. You can't tell by their shape what they are, except that they're rods. And this, there we go. You get some of these kind of curling around, look like fishing worms. Those are called treponemes or spirochetes. These happen to be long ones, and those are very invasive. Most people know that treponeme burgdorfii is related to Lyme's disease. Treponema pallidum is the cause of syphilis. These are Treponema denticola, probably. They help participate in periodontitis. And this is taken off of an implant. It's called a corn cob formation for obvious reasons. So the bacteria, they make great pictures to hang on the wall. If you don't label them, they look like modern art. I included this for Linda's. She likes medieval history. Periodontal disease started out as peridara in Sanskrit or Egyptian. Medieval times they referred to it as a corruption of the gums. And I don't know where the word gums came from. I wish it had never been invented, but we have it. Then in the 1600s it graduated to pyorrhea alveolaris, and then alveolodental pyorrhea, and then Riggs disease, named after John Riggs in Ohio because he made a name for himself treating it. Chronic suppurative periodontitis, periodontal. When I was in the military, in the Army, and this was 1976 or 77, I guess, I joined the Army Reserves. The forms they had to do dental exams on were still using this word periodontal. We hadn't called it that by the time I was in, probably 30 years, but I'm sure the government made up millions of documents, forms, and they had to use them up. And then lastly, periodontitis, and we stage it from 1 to 4, 1 being incipient or just initial level of disease, 4 being very severe. It starts out, we measure it with a probe called a periodontal probe. The depth of the collar around the tooth, any one tooth, should be somewhere between 1 and 3 millimeters. And that's what they're measuring here. And gingivitis is still a little about that same depth. It may swell, which will increase the depth, but we don't worry about the swelling because we can easily treat that. However, if you have bone loss, that depth deepens, and it becomes a different kind of treatment, much more difficult. And that is periodontitis. And then this would be severe periodontitis. Lots of inflammation, a lot of bacteria in that pocket.
Can I ask a question?
Yes.
If we go back to the pictures you just had, so I know the bone is the stuff that looks like cobblestones. What is the red stuff the gum tissue then?
Right here,
Yeah.
that's inflammation in the gum tissue.
Okay. And what type of tissue is a gum?
Skin.
Skin. Okay.
It's a little, histologically it's a little different, but basically it's skin.
Okay.
It has a keratin layer. The part you can see visually has a keratin layer on it, just like your epidermis, your skin. That's what peels when you get sunburned. That and upper layer epithelium. In the pocket area where that probe is inserted, that does not have a keratin layer. So it's kind of a weak point in the defense of the body. In fact, now that you bring it up, you didn't ask this, but I'll tell you. The mouth is the only place in the human body where a mineralized tissue pokes through the skin. So that is a weak link in the chain of defense against invasion of bacteria. Yeah, Wayne?
Can we say that? So when you get certain age, let's say after 65, 70, so people normally should have the something, either stage 1, stage 2. Is that correct?
No.
Okay.
Age, that was an old wives' tale that stuck with us. I still hear it all the time. Age has nothing to do with the health of your mouth. It can make you more susceptible, but slightly so, to the development of some diseases over time because our immune system is not as effective as we get older. But for the most part, if you have good on my mouth, I don't have any pockets, and I'm 85 years old. But I get my teeth cleaned about every 4 months. Probably don't have to, but I do anyway because I get it done free out of my old office. And I like the hygienist, so we sit and talk, and they pick around on my teeth. But no, age has really not much to do with it. Age doesn't have much to do with how we heal either. We used to think that you heal slower and maybe not as fast or as well as you age. That's a misnomer. Modern biology has shown that's not true. So we've graduated kind of from a normal mouth, and now we've quit brushing our teeth for 14 to 21 days, and we're developing inflammation. We're collecting plaque. The tissue is swelling, and you'll notice when it swells, it's more difficult to clean it because the architecture changes. It goes from nice, smooth adaptation to this bulbous, red, inflamed tissue between the teeth. It's always worse between the teeth than it is on the front or the lingual surfaces, tongue surfaces, or tongue side, because most people don't floss. They don't clean between their teeth. And that's where the disease usually begins. Periodontitis is just bigger and better. Now you're losing bone. The pocket around the teeth is deepening. The amount of plaque is collecting is greater. Some of that plaque begins to mineralize and becomes calculus or tartar. And that contains viable bacteria, believe it or not, so that if it isn't removed, it'll perpetuate the disease. An extremely advanced disease, it may be that a disease has been there so long that the tissue on the surface has now become fibrotic. The inflammation on the surface has subsided. That inflammation and infection has moved apically along the root of the tooth. And you're losing bone. That bone should be up around this area, and it's way down here. That would be a stage 4 periodontitis. And if you look at it, it doesn't look all that bad, does it? So a lot of times people have had disease for a long time and they go online and they get some snake oil that's going to cure their gum disease. They rinse with oil. Coconut oil is a common one. The inflammation disappears, but the infection's still there. It's just moved deeper. Implants have the same issue. We call it periimplantitis instead of periodontitis. You can get inflammation and infection around implants just like you do teeth. And in fact, it's a little easier because you don't quite have the same apparatus around an implant as you have a natural tooth. A natural tooth has what we call a periodontal ligament. It's kind of like the springs on a trampoline. It allows that tooth to move up and down. You don't have that with an implant, so it's easy to put stresses on the bone directly that a tooth will not do. That causes bone loss around the implant. Like you see here. And these threads, implants, are basically titanium screws developed by engineers. Sometimes they spray plasma spray coat them so it has a rough surface, allowing the bone cells to grow into that roughness and anchor it. But if you have any bone loss, now that rough surface harbors bacteria. So it's kind of a 50-50 proposition. And in fact, when you put in an implant, you get mucositis around it, and up to almost 50% of the cases, mucositis is basically gingivitis. You get periodontitis in about 20 to 25% of the cases, and you have a 5-year failure rate of up to 15%. So implants are not the answer to everything. Keep your teeth. Your natural teeth are best. I've mentioned inflammation repeatedly. In pathology, we teach students to recognize inflammation clinically, visually, by the color, rubor, redness, by swelling, changes in the architecture, I say, because of the swelling, the bulbous nature of it. Tumor is the name for that, Latin term. Bleeding on provocation. If you use that probe or you use a toothbrush and you get bleeding, that's inflammation. Pain, dolor, increases in temperature. We don't measure that, but researchers will, but clinically your dentist will not. Calor, and then loss of function of functiolese. By loss of function, we're talking about pain and swelling causes people not to want to chew on it in this case. The clinical symptoms are visual and by provocation. Bleeding on probing, as you see here. And then the red toothbrush that Colgate and Crest toothpaste like to talk about. That's what it is. So the question becomes this: is that inflammation and the bacteria that cause that inflammation related to atherosclerosis? In other words, this bug, Porphyromonas gingivalis, and this disease, can they convert this healthy artery to one that's beginning to plug up with an atherosclerotic plaque? Way back at the turn of the last century, Foster Johns and Charles Bass, and there is a technique of brushing your teeth called the Bass technique, and it's named after him. He proposed it for all of his patients. They stated that it's probable, quite likely, that the bacteria associated with gum disease has a gateway into the bloodstream in those patients. Yes, sir.
When you state it would seem, how strong is this seem?
It does, period.
Is that accurate or?
But they couldn't prove it back in 1915, so they said it seems likely. They were through a process of just observation of patients. They were kind of assuming that that was going to be the case. We now know that to be the case. In fact, if you have any degree of inflammation in the mouth, just masticating a meal will cause bacteremia, bacteria getting into the bloodstream. Our immune systems are very efficient, so they tend to take care of it pretty rapidly. So it seemed it was biologically plausible. It took until about this was developed about 1990 probably, to determine a mechanism for all of this. You start out with periodontal inflammation. And there are three pathways from that. You can have bacteria over here, or you can have bacteremia and lipopolysaccharide, which is endotoxin. And it's called bacteremia or endotoxemia. Inflammatory mediators and an immune response. This and the mediators all go through the liver. All blood passes through your liver eventually. The liver detoxifies that blood. But in the process of dealing with inflammatory mediators, bacteria, and endotoxins, the liver reacts by producing a variety, this is just 3 of them, different types of proteins: C-reactive protein, serum amyloid, fibrinogen. All of those participate and contribute to the process of atherosclerosis. That in turn is associated with cardiovascular disease and cerebrovascular disease. Stroke, basically, ischemic stroke. You have immune response with different types of antigens and antigen-antibody reactions, and individual bacteria can cause coagulation of the blood if it's an extreme. The strep gordonii there is quite often found on the heart valves and endocarditis. It'll colonize the heart valve. And then as your heart beats, it'll throw off a bolus of these bacteria, which now make it their way eventually to the peripheral vascular system or maybe into the brain, and you have an ischemic stroke due to a plating up of a small artery. So, we start out here. I've boxed in an area that we're going to look at. That's what it looks like histologically. And remember, Wayne, I think, or somebody asked me about the skin. You don't have a keratin layer on the skin, or on the pocket area. Right in here. See, this is the keratin layer, and that's what you see when you look in the mouth. This is the margin of the gum tissue. That space would be the enamel of the tooth. And this area under the enamel is what we call dentine or dentin. But that's the epithelium. You look at this layer compared to that layer, and they're very different. One has a keratin layer, the other doesn't. One has a lot of space between the individual cells, the other doesn't. That space, spatial arrangement, allows bacteria, toxins of various types produced by those bacteria, to gain access to the underlying connective tissue where the blood vessels are, and you get an inflammatory response, an immune response, and you get bacteria, bugs going into the blood system, bacteremia. So we look at that area. This is what a diseased pocket looks like. You got a question? You're looking.
Not yet.
Okay. This is all inflammation. You don't see that over here. There's a little blood vessel there, a few inflammatory cells around it, but that's kind of normal. This is all plaque. This is what we would call the planktonic plaque. This is attached plaque. Then you have plaque attached to the epithelial surface here. And some of this is going to invade ulcerations in that epithelium. So Bass was right back in 1915. It's quite likely you're going to have invasion of the blood vessels. In fact, if you assume 28 teeth in the mouth, you've taken out your third molars, and we assume a 6 millimeter pocket around every one of them, and you calculate the surface area that represents, it represents roughly 20 square centimeters, the surface area. That's the surface area that is presented to the bacteria in that pocket for possible invasion of the tissue. And that was done by a fellow by a biostatistician the name of Patrick Hujol, the University of Washington, way back in 2001. This is a 20 square centimeter piece of paper, and that's the palm of my hand. Now you look at that on an ankle, diabetic ulcer, and that represents the size of the ulcerated area, the aggregate of the ulcerated area. Now I would suggest to you that if you walked into an ER with an ankle like that, you'd be put on systemic antibiotics, they'd do an A1C on you, and they'd probably send you up to the endocrinology ward and start debriding that wound, trying to get it to heal. But we can walk around with teeth that have that much ulcerated area around them and nobody thinks a thing about it until you have a problem, systemic problem. Richard Ross, way back 1999, was the first one to just come right out and say it. Medicine had been kind of prancing around the periphery on this, and nobody wanted to take responsibility for it. He said that inflammation, atherosclerosis, is an inflammatory disease. Inflammation plays a role in the initiation of the disease, the growth of it, the increase in size of the atheroma or the plaque, and the rupture of that plaque. Of course, when it ruptures, you're in trouble. You either get peripheral artery disease or you get a stroke or a heart attack. A few years later, 9 years later, the Vincent Friedwald, who at that time was the editor of American Journal of Cardiology, came right out and followed it up, and he says, yeah, acute coronary events are increased in patients with other chronic inflammatory diseases, including, and he put in there, periodontitis. This was one of the first mentions that gum disease could be related to coronary disease. That was followed up again by Friedwald and Ken Corman, John Beck, Robert Genko. Those guys were all periodontists at the University of North Carolina. Corman lived next door to Friedwald in Boston. They talked a lot, I guess, over the fence, had common interest in inflammation, obviously. And so they put together a kind of a consensus group of experts, and they looked at the medical and dental literature, and they published simultaneously in the Journal of Periodontology and the American Journal of Cardiology these articles. And in those articles, they came to these conclusions. Atherosclerosis is present in many patients with periodontitis. It's an independent risk factor for coronary artery disease, independent risk factor for all forms of cerebral vascular disease, especially ischemic stroke. And it appears it may be an independent risk factor for peripheral artery disease. And you know, when I was at the school, and I'd go over to the medical school and I'd talk to some of the cardiology residents, they didn't believe it. They wouldn't buy it. And it's in their own literature. More recently, this is 2021, they looked at 12 different studies, showed consistent detection of pathogens in coronary atheromas, plugged up arteries in the heart. And there's that book, including with Porphyromonas gingivalis being the most commonly found organism. Porphyromonas gingivalis is a gram-negative, little short coccobacillus covered with pili and fimbriae. I call it bug hair. The only difference is the fimbriae are a little longer and the pili are a little shorter. It secretes membrane-bound vesicles, like little balloons coming off the wall of the bacterium, filled with endotoxins, and something called gingivalis. And those are just deadly to human tissue. And that sucker invades the minute it gets a chance. They find it in the brain and Alzheimer's, they find it everywhere in the body. You do not want Porphyromonas, and the only way you get it, periodontal disease. Journal Circulation, which is published by the American Heart Association. Periodontal disease can reduce inflammatory, evidence shows that treatment of periodontal disease can reduce the inflammatory mediators, factors, and improves intermediate risk factors associated with cardiovascular disease. So that's kind of a step in the proving of a really strong risk factor or association. It doesn't prove causality. Open access 2025. This is just late last year. White matter hyperintensities. That's everyone in here probably has some level of what's called white matter disease. It's as we get older, the small vessels in the cerebrum in the brain get smaller because of some degree of atherosclerosis. That kind of cuts back on the oxygenation of that tissue, and we begin to forget names. We begin to forget dates. Our phone number that we had in 1940, although I can remember mine, Clifton 2. Yeah, Clifton 2 9949.
1173.
We begin to have little lapses in memory. That's called white matter disease, and it's very common at our age. In this study, after they adjusted for all the variables, age, sex, high blood pressure, diabetes, smoking, ruled those out statistically, they were left with a 50% higher odds of people with periodontitis falling into the highest quartile of white matter hyperintensities. In other words, the periodontal disease increases your white matter disease. You're a little more forgetful than you would be otherwise. And that brings us then to infections, chronic inflammation, atherosclerosis, and Alzheimer's disease. Alzheimer's, from what I have read, and I've read a lot about it in the last couple of years, is a multifactorial disease. Thus far, we've been able to pinpoint any one etiology. It seems that there are a lot of things in play. Yeah, amyloid plays a factor, so does tau protein. But those are the result of the disease more than they are a cause of it. Vascular impairment, atherosclerosis, plays an onset and probably in the progression of the disease. Alzheimer's affects certain areas of the brain predominantly. It probably affects all areas of the brain, but it seems to be localized to certain areas, and those are the areas that we see manifested in the clinical responses. The primary somatosensory cortex in the posterior parietal lobe. The brain, I don't know if you're not familiar with the brain, you got a frontal cortex, frontal lobe, you got two parietal lobes on the side here, you got a couple of temporal lobes, one on each side, and back here is the occipital lobe, and right below that is a little cauliflower looking thing called the cerebellum. And they all, different functions are located in different areas of the brain. So Alzheimer's, the amyloid and the tau proteins tend to build up in areas like right along in here, the amygdala, the hippocampus, which is called the mediotemporal lobe. This is the temporal lobe. This would be the occipital, that would be parietal, this is frontal, and that's the cerebellum. All these areas are affected, and the dorsolateral prefrontal cortex is what robs you of how you react in conversation, how you correlate what you see with what you're being told, with what you've just read. upper level functions. Well, it turns out, again, late last year in journal Frontiers in Immunology, which is a well-respected journal, that oral bacteria and cognitive decline are being discussed as one related to the other. The oral bacteria in this case, again, is Porphyromonas gingivalis. I mentioned the gingipane secretion by Porphyromonas gingivalis. This, I don't know Lighthouse Pharmaceutical, but they've been awarded a $49 million grant to actually investigate the role of Porphyromonas gingivalis as having a primary role in Alzheimer's. PG, or Porphyromonas gingivalis, is referred to as a keystone microbe, which basically means that you don't need very many of them. Through the exchange of RNA and DNA with the bacteria around them in plaque, they can take a perfectly non-pathologic bionome and convert it to a pathologic bionome. It's kind of like Bibi would be very pacifistic, and I'm a PG. We can exchange DNA and she becomes a killer.
Okay.
Okay. This is kind of what we're looking at. This is a biofilm from a severe periodontitis pocket. And if you look at all the different sizes and shapes there, for instance, here is a long fusobacterium, probably a fusobacterium nucleatum. Long rod, straight rod, little sausage here. These are real sausages. And right in here, spirochetes. You can see how they're coiled and bundled up. Well, where's the Porphyromonas gingivalis? There's 1, 2, 3, 4, 5, 6, 7. Not very many of them there. It's a keystone microbe. It doesn't take very many of them. It's the director of the choir, and it's a big orchestra. You remember I said it has fimbriae, these long things here. The pili you don't see so much on this. It has these vesicles that it's secreting. And those are all virulence factors. So after reading about this for several years, I decided to write a paper on it. And it's in press in the International Journal, or Journal of International Academy of Periodontology. And this is kind of the paradigm that I proposed. Periodontitis has chronic inflammation, tissue degradation, transient bacteremia, Porphyromonas gingivalis, endotoxin, all these virulence factors, which cause systemic infections and increase the inflammatory burden of the body. You can have inflammatory bowel disease, psoriasis, tonsillitis, and periodontitis. That's all increasing that inflammatory burden because they're all inflammatory problems. And that in turn can lead to microglial cell and astrocyte cell activation in the brain, and they begin to produce inflammatory mediators, particularly the glial cells, which are basically macrophages in the brain. And that inflammation ends up in the production of what's called tau protein neurofibrillary tangles. The nerve endings, or the nerve axons and axonites in the brain get all tangled and they go into the amyloid plaque and never come out again. So your nerve transmission doesn't pass through and you're short-circuited basically. Alzheimer's is not a disease of just the people, of unintelligent people. This is a Nobel Prize winner whose son said that he died of complications from Alzheimer's disease. And if that isn't bad enough, they're finding that certain bacteria like strep mutans, which is very common in the mouth, it causes dental cavities, may play a role in Parkinson's disease. It produces an imidazole propionate, which we've known about for years, but that seems to play a role in Parkinson's and neurodegeneration of Parkinson's. Or the Porphyromonas gingivalis has been, in the cancer literature, is gaining more and more prominence as being related to susceptibility to cancer, this various types. Here, a 3 times greater risk of developing pancreatic cancer. All of those bacteria on the list there, PG, Bacterium notatum, Porphyromonas micro, they're all oral bacteria. Fusobacterium nucleatum, a role in breast cancer maybe. This is brand new, 2000, January this year. So, to conclude this, pathogenic bacteria, the gum disease called periodontitis, the inflammation resulting from that interaction is an association. It is a comorbidity, and it is certainly a risk factor in these other diseases. It doesn't cause any of them, but it is certainly an independent risk factor. And I will tell you, there is absolutely nothing good about chronic inflammation in the mouth or anywhere else. Never has been, never will be. Questions?
I'm rushing home to brush my teeth.
You've already done it, I can tell.
I have two questions. One is for people with, say, medium gum disease, is that cultured very often?
Culture?
Yeah.
Yeah.
And then two.
Not in clinical practice, but in a research environment.
So not in clinic.
Mm.
And then for the P. gingivalis, is there an effective
Antibiotic?
Yes.
No.
Bummer.
Vaccine, there was a group in Australia that investigated this extensively. They spent several $1 million. They developed a vaccine that seemed to work in monkeys. When they took it to the humans, it didn't work. So it's back to the drawing board. But on the other hand, if you take care of your mouth, you never collect enough PGs to make a problem.
So you said that if you don't brush your teeth for 14 days, things can develop. And you also mentioned that if you don't brush the right part, I mean, you could be brushing your teeth, but you might not be hitting something. So I guess if you I guess my question is, you mentioned somebody developed a way to brush your teeth. So what is the best way to brush your teeth?
An electronic toothbrush.
Okay.
Really. I don't use one because it makes me gag, but that's me. For most people, a electronic toothbrush is probably 5 or up to 10 times better at removing plaque. If you just hold it in place, let it do its thing, move it, you know.
It's funny you say that, because I used to brush my teeth with a regular toothbrush, and now, gosh, for the last, I don't know how many years, I've been using one that has a battery in it, so it moves.
Yeah.
And my hygienist hasn't had to do as much work on my teeth
Well, it's
since
more
I started
efficient.
doing that.
Yeah, it's more efficient. It just stands to reason. If a manual brush, you're just going like this as fast as you can go. I don't know how many strokes a minute that is, but say, what do you think, Jim, 100? With an electric brush, in a minute, you'll do 5,000, you know, because it's going like crazy. Plus, it sets up a cavitational effect of the water or the fluid in your mouth. And that kind of gets in between the teeth and flushes things out with bubbles and whatever. It's just more efficient.
And I assume flossing is still something you need to do every day.
Yeah, you know, either that, you gotta put something between your teeth every day. You don't feel it, but there's plaque or food debris there. You can buy interdental cleaners in the drugstore, little rubber cone-shaped things that'll go between the teeth. Little brushes that go between your teeth. They're very efficient. I like those better than floss, actually. Done? Thank you.
Wonderful.
Keep it in a good class.